Just the observation from an old guy. I listened to those last two presentations, and it makes you proud to be a member of this profession. This is not the same profession that I started in 1973. It's the education, the research is just amazing. And the last two speakers are something to be proud of. Just a couple of words about the International Working Group on the Diabetic Foot. They recommend that you don't tell patients they're cured of osteomyelitis. Tell them they are in remission, and they recommend that you follow with them at a minimum of 6 months. As far as Charcot joints go, I think that the speaker underestimated the risk. If you don't know, the average life expectancy of a patient from the day you diagnose them with a Charcot joint is 7.88 years. And their 5-year mortality rate is just over 44%, like 44.8%. So these are pretty sick patients. And the current recommendations for non-operative care, if they don't have an open wound, is make sure if you put them in a well, you should cast them or put them in a long leg boot. It should be below the knee, not short leg. They have to be totally non-weight bearing. In monitoring them, you should be doing thermography. We do that in our office. And you want to look for a less than 2 degrees centigrade difference between the involved and the uninvolved foot, 4 degrees Fahrenheit in those patients. And interestingly enough, there's no literature to suggest that operative intervention is superior to non-operative intervention in the management of the Charcot foot. If a Charcot patient develops an ulcer, the statistics are basically they're 8 to 15 times more likely to have to require an amputation. So I do tell that to my patients that if you get a wound, you're 8 to 15 times more likely to lose this leg. So if you want to play and not listen to what we're going to say, you're going to take that responsibility, and I document that. Okay, with that in mind, I was asked to cover a simpler subject, and that's skin disorders in the diabetic foot. And again, just to summarize things, you know, what's your job as a podiatrist with these diabetic patients? They come to your office and they say, why are you here? Well, I'm diabetic, and my doctor said I shouldn't cut my own toenails, and that's why I'm here. And that's the last thing that goes on in my office. Your job, and I explain this to the patient, day one, is to lower their risk for an amputation, lower their risk for a significant event. That means I want to identify all these risk factors that are in front of you. That first visit is very, very important to establish turf, to identify these risk factors and then treat them. And if you're in everyday practice, then certainly skin disorders are a part of this. We see more than just onychomycosis, and you see variable estimates regarding the incidence of these skin problems in our diabetic patients. Just quickly, these are some of the ones, diabetic dermopathy or shin spots, those macular lesions that are brownish color. Patients say, what are these? Necrobiosis, where you have to be careful with that is if they ulcerate, you have to biopsy these to rule out squamous cell. Of course, we see a lot of fungal and candidal infections. We see a lot of vasomotor changes in our diabetic patients, their skin. That's why their skin is dry. The first manifestation of diabetic neuropathy is typically small fiber neuropathy with loss of innervation of the sweat glands. And that's why from the very time you begin treating diabetic patients, you're taught their skin is dry. And if you were to do a punch biopsy, you'd see that they've lost innervation of their sweat glands, so they have vasomotor, pseudomotor changes. Vitiligo is common in our African-American patients, idiopathic bulla of diabetes, and of course, a variety of infections. So I'm going to go over these quickly. And again, it's as I mentioned with musculoskeletal disorders, all I could do is remind you of some of these things, and you have to go about learning about them themselves. We emphasize early recognition and early treatment and monitoring of follow-up. As you'd imagine, there are differences between diabetic skin and non-diabetic skin. Diabetic skin is basically advanced aging. We have abnormalities in the skin cells themselves, deposition of advanced glycosylated end products, as you'd imagine. We have reduced nitric oxide synthesis so that we have vasoconstriction. We have reduced immune function, a variety of effects that we don't have time to really go over in detail, but as you'd imagine, there are effects of advanced glycosylation end products. This is a neuropad, something I use. There's to measure sweat function. Many of our diabetic patients, the first thing they lose is sweat function. And you can measure this if you want in your office. I do. Not everybody has to do this. This causes dry skin, encourages the growth of candida species and dermatophytes, and encourages bacterial infection. Interestingly, the most advanced typical small fiber neuropathy changes are found in the hallux and under the first and second metatarsal heads. Maybe it's not a coincidence. These are common lesions for these ulcers. These small fiber neuropathies, as you know, begin in the unmyelinated fibers, and they affect temperature and sweat. And this is an example where biopsy is typically done with a 3-millimeter punch. If you need to confirm the diagnosis, I'm not suggesting you do. The middle shows a normally innervated sweat gland. The one at the bottom of the screen shows one that lacks innervation. The same staining is for epidermal nerve fiber density testing. So these are the patients that have these vasomotor and pseudomotor changes. They get this dry skin, these dry calluses. I don't need computerized studies to tell me that the patient to your left is going to be ulcerating under the first metatarsal head or cuboid, or on the right, the fifth metatarsal head. I think you could read a lot of these feet as well as I can. A lot of times we have these patients that are diagnosed as having tinea pedis, and in fact, the majority of these patients, over 60%, have pseudomotor deficit, and that's what I put in their chart. They also have increased or loss of normal barrier function, increased water loss, and that's why hydration is so important. Instituting various emollient therapies, hydration therapies, and I charge for these, even if they come in for routine foot care or nail care. If I'm treating these things, I make the diagnosis, I document this diagnosis, I treat them when they come back. I evaluate the response. I add an office visit with a 25 modifier. That is my job, is to identify and treat risk factors. Because of their immunopathy, and you said it well, these are sick patients, and we have to remember that. We're not treating healthy patients. These are patients with diabetes. They have impaired immune function. And a lot of these things are minor, and I tell the patients, listen, this is like Benjamin Franklin. You know, the old, for lack of a nail, a shoe was lost. For lack of a shoe, a horse was lost. For lack of the horse, the rider was lost. And for lack of the rider, the war was lost. And I tell them, day one, when I first meet these diabetic patients, and don't forget, you can bill for your time now. So you don't have to have a long laundry list of make-pretend diagnoses. You can take your time, evaluate these patients, list the risk factors, discuss with them how you're going to intervene for each of these, and bill for your time. You're entitled to do that. And I explained this to them, that the majority of times we lose legs in diabetes, it starts with some stupid minor problem that could have been addressed earlier. And look at some of these studies that show, for example, patients that have had amputations and ulcerations. Look at the risk factors most commonly: tinea pedis and xerosis. Simple problems. Another one, predicting foot ulceration, a study out of the Seattle VA. Tinea pedis and onychomycosis, right there. These are not minor problems in the diabetic patient. And here again, tinea pedis, onychomycosis, interdigital tinea pedis, increased association with infection, osteomyelitis. So you've got to explain this to your patients, let them know that in a 20-year-old healthy athlete, maybe it's just athlete's foot. In you, it has to be treated. And then when they come back, you monitor their response to treatment. You make a decision, continue that treatment, alter the treatment. Are they being compliant? And you charge for that. Again, another study showing the same thing: increased risk of ulceration with simple problems like tinea infections. Xerosis is very, very common in our diabetic patients, and you want to treat this aggressively. I use this particular diagnostic code, and I institute therapy. Typically, I use a lot of urea-based therapies because I like the antifungal effect with the urea in addition. And again, I'm going to have them come back and monitor this. And typically, when I see feet like this, I also include a co-diagnosis of pseudomotor deficit. Itching in the diabetic foot. Remember that itching can also be a manifestation of neuropathy. So if a patient's complaining of pruritus and you can't find a dermatologic basis for that, consider the possibility that it's a manifestation of sensory neuropathy, and sometimes treating them with a tricyclic or an SNRI or a gabapentinoid or whatever medication you like to utilize for treatment of diabetic neuropathy can be helpful. Sometimes rather simple measures like L-methylfolate, B6, B12 supplementation is helpful for many of these patients. So keep that in mind. Cellulitis occurs very frequently in our diabetic patients. Don't give up your coverage for staph and strep. And we know that diabetic patients, yes, when they have chronic ulcers, they pile up these multiple organisms and gram-negatives, but when you have a cellulitis, consider strep and staph still most commonly. These are recommendations from the Infectious Disease Society of America. Work on reducing their edema. Edema is a risk factor in these diabetic patients. They get swelling for whatever reason, kidney, congestive heart failure, antihypertensive medications, fluid electrolyte abnormalities, whatever, and their shoes don't fit. They don't feel that because of their neuropathy and reduction of it, and they get ulcers from that. So there's only so much room in a shoe. If they've got hammer toes and bunions and now they're swelling, this is a prescription for problems. So you want to reduce that edema, treat their interdigital infections, and again, if they've got chronic eczema, if they have venous insufficiency, you should start treating these things, and again, web space infections. Looking at onychomycosis, it is associated with increased risk of gangrene and ulceration. Again, I mentioned a number of these studies that show a definite relationship between simple fungus infections. This was from Jeff Robbins' classic work, study of VA patients showing the association of tinea pedis with secondary foot infections, gangrene, and you can see the relationship. And so onychomycosis should be treated aggressively in the diabetic patient. Should you get cultures and PCRs, for example, two circumstances. One, if you're going to be using an expensive medication, and number two, if you're going to treat them systemically. And you should be using oral medications to treat these diabetic patients. You've got numbers of patients, papers now to show the safety of treating onychomycosis with oral terbinafine or diflucan or itraconazole in these diabetic patients. Get your baseline liver function studies or get a CMP, repeat it, look at the patient's history, but you should be aggressively treating these patients with these medications. And for many of our older patients, bending over and spending their lives applying topicals is just not practical. Tinea pedis, again, occurs with increased frequency in our diabetic patients, needs to be actively addressed. Interdigital tinea pedis also needs to be actively addressed. Make sure you're getting cultures between these toes. They could have tinea pedis. They could have a candida infection, erosio interdigitalis, blastomycetica. They could have gram-negative infections between the toes. They may have combinations of candida and secondary bacterial infections, so you need to culture them. These web space infections, I've seen in my life quite a number of patients who have gone on to have significant infections that started with simple web space infections. These three patients all ended up losing their legs from what started as simple interdigital space infections. So get cultures, find out what's between those toes, treat them aggressively. Similarly, heel fissures can break down, crack, result in ulceration. These things should be aggressively treated in your diabetic patients. Diabetic dermopathy, these are the patients that say, what are these brown spots up and down my leg? These are macular lesions. They're typically not symptomatic. They're flat, they're brown, they're not hyperpigmented around the edges. They're frequently associated with elevated hemoglobin A1C. So they're typical shin spots, if you will. They're typically anterior located, although you can see them in the backs of the legs, and they're asymptomatic. Not much is known as to how to treat these effectively or even the cause. So sometimes I'll recommend 15 to 20 milligrams of chelated zinc and then emphasize better control of their diabetes. Necrobiosis lipoidica, you get these shiny looking lesions, typically pretibial, but you could get them on the foot also. And they have this hyperpigmented border around them, and they have telangiectasia that cross these lesions. They're typical maculopapular lesions. So you see this typical hyperpigmentation. This one is ulcerated, requires a biopsy. You see these telangiectasia. This is atrophy of the epidermis and dermal tissues. Then this is the typical presentation. Here again in the back of the leg, and here you can see this typical hyperpigmentation, telangiectasia, that shiny appearance to them. And where they become worrisome is when they ulcerate like this. And again, you see typical presentation of necrobiosis lipoidica diabeticorum, but this one has ulcerated that needs to be biopsied to rule out squamous cell carcinoma. If they are not squamous cell, these are the treatments. Some of them are appropriate for podiatry. The only problem is, of course, whether you're comfortable using steroids in a diabetic patient. Sometimes old-time pentoxifylline, 400 milligrams TID is sufficient. Sometimes they respond to aspirin. Otherwise, you might want to refer them out to derm if you're not comfortable with some of these other treatments. This is one of my favorite disorders. I see this quite a bit. I'm always surprised how little this comes up at our meetings, and that's idiopathic bulla of diabetes, where these diabetic patients develop spontaneous blistering of their feet, their ankles, and their legs. And I had a patient that I had done a pretty risky Charcot recon on with internal fixation surrounded with a frame. The guy did well for 1 year, then got idiopathic bulla of diabetes a year after a successful recon, got a staph infection in the hardware from his idiopathic bulla, end up with an amputation. So I know this can do some damage. It's more common in patients who have various stages of CKD. Typically, these bulla heal in 2 to 6 weeks. They present, and some of them ulcerate. When they ulcerate like this, they have a high incidence of staph and MRSA infection associated with them. So you aspirate them. If you're concerned about some bullous disease, pemphigus or pemphigoid or some other bullous lesion, you certainly can biopsy it and send them to pathology if you want. Typically, they're like any other blister. If you leave it alone, leave it alone. If you're going to cover them for anything, cover them for staph. Lastly, granuloma annulare. These are, or next to last, these are pretty much asymptomatic. They almost look like you have parasitic infection under that skin with a ringworm-like a presentation. They're common on the foot. They're macular, non-pruritic. This is what the biopsies look like. And vitiligo in patients of color is not uncommon, not a whole lot we could do for that. So in looking at everything we've heard today about, in my example anyway, with metabolic bone disorders and disorders associated with increased frequency in the diabetic patient, we look at ourselves and we say, what's going on? And we heard some talk today about changes in medicine. Sir William Osler, who's pictured here, and again, the man who's considered the greatest teacher in the history of medicine, he used to start his medicine class every year by telling the students, he would say, gentlemen, and I apologize to you women, but back then women were not a big part of medicine. In fact, in my podiatry class in 1969 through 73, there was one female in the entire school. So it was men back there. And he used to say, gentlemen, 10 years from now, half of everything I teach you will be proven to be wrong. The problem is I don't know what half that's going to be. And that's the trouble with what we're doing. We have changing understanding of many of the disorders in the diabetic patient. When I started practice, we never saw a diabetic patient. I remember being a student at PCPM. I had my little short white coat on. It was my first day in clinic. I went to my clinician. I said, I got a guy here. He's diabetic, and he's here to get his toenails cut. And my clinician looked at me and said, cut his nails and get him out of here before something happens. I was thinking, holy shit. Like this. Now, you think about the irony. Medicare still reimburses you to do nail care on these patients, and we're slamming IM nails in them. We're putting frames on them. We're doing beams and bolts, and yet we're still worried about, well, if you nick yourself cutting your nails, this could be a problem. Kind of interesting. So it's like William Osler said, medicine is a science of uncertainty and an art of probability. So medicine or diabetes is associated with multiple risk factors. We talked about a couple of them today, at least I did. You heard from others, the various risk factors involved. Our job is to try to reduce the risk of amputation. That means identifying vascular disease, making appropriate referrals. It means identifying musculoskeletal problems, making appropriate referrals or treating them. It means identifying biomechanical factors that could predispose people to their problems before their problems, explaining it to the patient, because if you educate the patients, they will cooperate. It's when you don't explain things to them and don't take the time to educate them, in my opinion, that they stop being cooperative or say no to orthotics or say no to some prescribed medication. And the more you know about these various pathologies that could lead to skin breakdown and ulceration, the more you can identify them and intervene early, because this is what we all are in this business to prevent. We are inundated with diabetic patients, and I think that's going to continue more and more and more in our practices. So I thank the committee again for inviting me to share some thoughts with all of you, and I wish you the best for the rest of this meeting, and hopefully maybe I'll see you next year.